And these patients in many ways are harder than the patient that has an obstruction because we know the things that we need to do for those patients. But these patients are dangerous. I want to give you guys some of my contact information if you don't already have it. Inevitably, what ends up happening is some of the things I talk about end up being very controversial, and then people have questions. So you can get a hold of me. I'm very easy to get a hold of. I come all the way from San Antonio, Texas, but with the use of social media, we're all friends and we all stay in contact with each other. I wouldn't be here talking to you today if it wasn't for social media. For those of you who don't use social media, I have an email. I say this every time I speak. Please use my email to get a hold of me, and yet nobody ever emails me. So either I'm answering all your questions or you're intimidated. Everything we're going to talk about today, as I always do, I have on the blog and the podcast. Everything we're going to talk about is referenced on there. So what I want to spend more time talking about is a case that I had. So I've changed some of the scenario here, but this was a patient that I took care of 2 years ago. Let's call him John. So John was a homeless man that the gas station attendant called EMS to come pick up John because he wasn't acting himself. He wasn't acting right. And EMS brought John in, and as you can see, he doesn't have a single normal vital sign. He's hypotensive, he's tachycardic, he's hypoxemic, he's tachypnic, he's febrile. I don't think there's anybody in this room who's not thinking, we don't need to intubate John. The mistake most people make, however, is that they want to intubate right away. And this is why we're talking about the physiologically difficult airway. We're going to tackle each one of these individually, but the reality is in life, we tackle all these things at the same time. We're not going through each of these one at a time, but for the sake of the talk, I think it's important that we partition this. Now, John, at this time, has 2 of the 3 physiologic killers. He's hypotensive and he's hypoxemic. We'll come back to metabolic acidosis. So the mantra is resuscitate before you intubate. We need to resuscitate these patients. There have been several reviews, observational trials, retrospective trials that have gone back and looked at these patients that have either hypotension or hypoxemia. And what they found is that if you don't adequately resuscitate the patient, they will have post-intubation cardiac arrest in almost 4% of cases, anywhere from 1.7 to 4%. And that doesn't sound like a lot. But if you actually do the math, this is 1 in 25 to 1 in 60 intubations. It's not an insignificant number. We all see these patients all the time. So you can't just rapidly push induction agents, paralytics, and expect that patient to do well. You need to resuscitate them first. They're testing me. So let's talk about hypotension first. This is probably one of the more common things we see, and this should make you really nervous when you're getting ready to intubate a patient if they're hypotensive before you push medications. Now, I think most of us would agree that the first things we're going to do are we are going to give crystalloids to our patient. And what I want to advocate for here is that you don't just want to get 2 IVs. You want to get 2 large bore proximal IVs. I'm going to say that one more time. 2 proximal large bore IVs. So I'm talking 18 gauge or larger. And you want to be in the antecubital fossa or more proximal. Okay, I'm not talking about a dinky little 20 or 22 in the back of the hand or in the forearm. You want to go really proximal. Now, oftentimes these patients, they're in shock. So their veins are collapsed. It's very hard to get IV access. The one thing that I don't think we use enough is intraosseous access. And in a patient who's in shock and I need access, my nurses get 2 shots. And if they can't get me 2 IVs, we're moving on to intraosseous. So why am I advocating for intraosseous? Well, first of all, these are 15 gauge needles. This is bigger than the 18 gauge that I told you. And many people will talk about that you can put them in the proximal or distal tibia or the humeral head, or if you have the special type of IO, you can even go sternal. My preferred choice is the humeral head. This is close to the central circulation. Basically, anything I'm going to give through there, I know I'm going to get it to the heart quickly. Whereas if you go tibia, which is where most people go, it takes forever for that medication to make it around. I'd like to think of intraosseous access like IV access. Anything I can give through a peripheral IV, I can give through an IO. Only it's a non-compressible vein because it's in the bone as opposed to a vein. So basically anything you can give through an IV, you can give through an IO. That includes sedative medications and paralytics. This was a nice cadaver study that basically looked at two things. First of all, how successful are we as providers putting in intraosseous access? And you can see the first pass success was 100% with the humeral IO. It was 81% with the proximal tibia. And the most common reason it wasn't successful in the proximal tibia is people went through the bone. And so they were actually infusing fluid and medications into the back part of the lower extremity. The other thing that's really important is look at the flow rates. It doesn't sound like a lot, but 20 cc's is a lot faster than the 30 that you're seeing. So 57 versus 30 is a 20 cc difference. So I can get medications in a lot faster in my patients. So also really important to remember. So what are we going to do about the hypotension? So we've got our proximal IV access. I've already talked to you about intraosseous if you can't get IV access. So how are we going to medicate this patient? And this is where I'm going to advocate, and I'm going to be very careful about how I advocate for dosing your sedatives low or your anesthetics low and your paralytics high. So first thing to understand here is we already have a patient who's altered. He's clearly in shock. Shock in and of itself is a very powerful anesthetic. When we go to push a sedative agent or an anesthetic agent, we're going to do two things. Number one is whatever sympathetic response our patient can mount, we're going to take that away from him. So we're going to make him more hypotensive. The second thing that's about to happen is we're going to intubate this patient. So we're going to take him from a negative pressure system to a positive pressure system. This is going to decrease venous return, which inevitably is going to cause more hypotension. Now the thing that I want to be crystal clear about here is I'm not saying we want to give such a low dose that our patient is awake when we're paralyzing them, because that is torture by itself. What I'm advocating for is a lower dose. Start low, go slow. So enough to sedate the patient, but not so much that we make them more hypotensive. So this is going to be a very nuanced approach, a very individualized approach for our patients. Paralytics high. So why paralytics high? Well, this is a cardiac output dependent medication. In other words, in order for our patient to get paralyzed, that medication has to make it around. But when they're in shock, the cardiac output is decreased. So it takes longer for that medication to make it to the neuromuscular junctions. Nobody's overdosed by giving somebody too much paralytic. So we give more so that it gets around faster. We're going to come around to both of these things here in just a second. So if I could choose one sedative agent, it would be ketamine. I like ketamine for a lot of reasons, not personally, but for my patients. Typically we dose at 1 to 2 milligrams per kilo when we intubate our patients. I'm actually going to advocate for a lower dose of 0.5 milligrams per kilo. Ketamine is a great analgesic medication. It has the added side effect of increasing sympathetic tone. It increases cardiac output. It's a bronchodilator. And if not given too fast, it doesn't kill respiratory rate. So for multiple reasons, I love ketamine in these shock patients. I will give 0.5 milligrams. It has been very rare that I've had to give another 0.5 milligrams per kilo. but every once in a while I do have to give a second dose. The key here is enough to sedate the patient, but not so much that you make them more hypotensive. Now for paralytics, this is going to be dependent on where you work. So for a lot of people, succinylcholine is the go-to paralytic. And the dose is typically 1 milligram per kilo, but remember I told you we want to go at a higher dose because we are in a shock state. Cardiac output is not good. So people will advocate for 2 milligrams per kilo. This isn't my recommendation, people have studied this. Now the onset of action for succinylcholine is typically about 45 seconds to 1 minute, and it hangs around for about 8 to 10 minutes. You can certainly use succinylcholine, but in the last year or two in my practice, I have changed over to rocuronium. And there's some important things we need to talk about here. So typically rocuronium is dosed at 1 milligram per kilo. You're actually going to increase the dose to 1.6 milligrams per kilo. The three things I want to talk about here is, many people will ask the question of, but doesn't it take a few minutes for rocuronium to take effect? And the answer is yes, at standard doses, that is true. But when you increase the dose, its onset of action is just as fast as succinylcholine, 45 seconds to a minute. The second thing is that when you compare rocuronium to succinylcholine head-to-head in the anesthesia literature, rocuronium prolongs safe apnea time. Safe apnea time is the time that you push your induction medication, you push your paralytic, and the patient doesn't drop their oxygen saturation. You don't become hypoxemic. Rocuronium has been shown to have a longer safe apnea time. The final thing, and this is probably the most important thing, and if you ever work with me, this is your number one way to get your rocuronium privileges taken away, is that rocuronium hangs around for 45 to 50 minutes. You need to start a sedative agent on your patient. Once you've intubated them, you need to start whatever medication that is, whether that be propofol, whether that be Versed, I don't care what you use, but you need to start something. Imagine laying in that bed, your sedative wearing off, and just being paralyzed and completely aware of it. That's torture for the patient. So that's the third thing, is you need to start your sedative medication after you've intubated that patient, because this will hang around for 40 or 50 minutes. So this combination has been dubbed roketamine. I wish I was the one that came up with this name. But basically the combination of low-dose ketamine and high-dose rocuronium in patients in shock. This is the recipe I am using for these patients. So the next intervention is push-dose pressors. And we can talk about all different types of agents, but in my mind there's only one. It's epinephrine, because you get both alpha and you get both beta agonist effects. And the way you make push-dose epinephrine is super easy. You take a 10 cc syringe, get rid of 1 cc, so that leaves 9 cc's of saline. And then you take an amp of cardiac epi and you draw up 1 cc from that. You've now created a 10-to-1 mix, which is basically 10 micrograms of epinephrine per ml. So every ml you're giving that patient, you're giving them 10 micrograms of epinephrine. You basically diluted your 100 micrograms per ml. You can give 1 to 2 mLs every 2 to 3 minutes, and you have to remember this isn't fixing anything. This is just buying you time. This is buying you time until you can do something more definitive for your patient. And that's intervention 2B, which is running pressors through a peripheral IV. Now, maybe in your institution, you have these drips ready to go. You have the pump ready to go, and you can just go ahead and hang up epi. And if it was my choice, this is what I would do. But in the community where I work, what I end up finding is that it takes time to mix the epi because it's not pre-mixed. It takes time to find a pump. It takes time to get that up and running. So I like to use push-dose pressors to buy me time so that my patient isn't in shock while we're getting this ready to go. Now, I don't know if peripheral pressors is something that's easily being used, and I'm finding more and more people are doing this, but there's some important things you need to understand about peripheral pressors. So first of all, there was a nice systematic review that was published back in 2015, and it had over 280 cases of pressors being run through peripheral IVs. And there were two major takeaway messages in that systematic review. The first is that 95% of extravasation events occurred after 4 hours. So the first message I want you to take away is it is okay to start your patient on peripheral pressors, but realize that after 4 hours, they need a central line. So don't just send them up to the unit without that central access. It's okay to start them that way, but it's not okay to continue that for more than 4 hours. The second take-home message is that 85% of the extravasation events occurred in IVs that were distal to the antecubital fossa, which is why I emphasized large bore and proximal at the beginning of the talk. So proximal IV, less than 2 to 4 hours. Don't get lazy, don't not put a central line in your patient, but at the beginning, when you're resuscitating them, it is okay to run pressors through a peripheral IV as long as it's large bore and it's proximal. Now this is a cool technique. I've used this a couple of times. I find that it's too laborious. It takes too many steps. There's too many things that you have to do. But let's say you have a patient in shock and you don't want to push rapid sequence intubation medications. Well, one thing you can do is an awake intubation. And this basically requires multiple steps. You have to think through this, and you need to have all the equipment and medications ready to go. We actually have a little kit that we've put together that has all these things in it. So this isn't something you're just going to reflexively decide to do. You need to have thought through this. So the first thing you're going to do is you're going to get 10 cc's of 4% lidocaine. Not 1%, not 2%, 4% lidocaine. 10 cc's, and you're going to put it in an atomizer. You can also do it as a nebulizer as well. Just like you would run albuterol, you can run 4% lidocaine. And you have that sprayed into the back of the oropharynx. The next thing you're going to do is you're going to get a tongue depressor, and you're going to get 2% viscous lidocaine. Now, don't jab this so far back in the throat that you gag the patient and they start throwing up. But you want it far enough back that when you turn that tongue depressor over, all that viscous lidocaine starts dipping down into the posterior aspect of the tongue and into the vallecula. So you can see how you're quickly anesthetizing that oropharynx. And then the last thing is you need some type of device. One of them is the magic device. This isn't the only device that you can use. But you need something to anesthetize the vocal cords and just distal to the vocal cords. So you take 5 cc's of that 4% lidocaine that we used at the beginning, and you spray that all over the vocal cords. Now you've completely anesthetized the oropharynx, the vallecula, and the vocal cords. And now you can go ahead and intubate the patient without pushing any RSI meds. And they tolerate this very well. Don't tell anyone, but I actually tried this on myself. It tastes terrible, but it works. You can't feel anything. So for John, what I decided, I'm not actually pushing the medications yet, but in my head I was like, we're going to give him some push-dose epinephrine to buy us some time. We're going to do some low-dose rocuronium, and we're going to do high-dose rocuronium and low-dose ketamine. That's what I had decided, so I had the nurses already working on that. All the references for this, wow, that's really fast, are right here. So if you have a QR code, go ahead and take a picture of that, and then I'll take you to the blog post, and it has all the references with all the PubMed links there, okay? I've also shared this on the WOVA app. I put all the links in there as well. Just look under Resuscitation Sequence Intubation. All right, let's move on. So now we got to deal with the hypoxemia. Maybe. So the first thing I'm going to tell you is that every patient we want to intubate, the key is pre-oxygenation. I know there's been a lot of talk about apneic oxygenation, but the key is pre-oxygenation. This is what staves off hypoxemia during intubation. It's not the apneic oxygenation itself. So you're gonna use something called no DSAT, nasal oxygenation during efforts securing a tube. This requires nasal cannula turned at 15 liters per minute and a non-rebreather turned up to greater than 15 liters per minute. I know most people, it only goes up to 15. Crank that sucker all the way up. It doesn't matter what you're giving, just go all the way up. After 2 to 3 minutes, if this does not get your patient's oxygen saturation greater than 95%, you need to start thinking about shunt physiology in the lung. There is something in that alveoli, whether it be infection, whether it be fluid, there is something that is not allowing oxygen to transfer to the alveolar capillary. These patients don't need more oxygen, they need PEEP. Positive and expiratory pressure. And my go-to maneuver in these patients is a bag valve mask with a PEEP valve. A PEEP valve is on my right, your left side of the screen. And it's very nice because it attaches to the bag valve mask and you can dial it up to 5, 10, 15, or 20. You're gonna take 2 hands, create a seal with that bag valve mask, and give your patient a nice jaw thrust to open up that airway. I guarantee this will help recruit atelectatic alveoli. So you're recruiting alveoli to compensate for the shunt that is happening in the lung. Now, in a patient who's breathing well on their own, they're ventilating okay on their own. In our patient, he was breathing 40 times a minute. You don't need to bag this patient. Bagging this patient is going to insufflate their stomach, and now you've made a physiologically difficult airway an anatomically difficult airway as they throw up their kebab or whatever it is that they ate. I did that on purpose. So this is called apneic CPAP recruitment. In other words, we're not bagging the patient. The second intervention that's an option is non-invasive ventilation. You can do delayed sequence intubation. And if I could just summarize that for you, it's basically procedural sedation for the procedure of pre-oxygenation. That's essentially what it is. So you give them some low-dose sedative, which we've already prepared and decided is going to be ketamine. You put them on a non-invasive mask, and you connect them to the machine. And unfortunately, we don't have a ton of evidence for this, but there's a lot of people that advocate for it. There's one observational study with just under 100 patients, and they tried delayed sequence intubation in these patients. It wasn't a randomized trial, so they weren't compared to a placebo arm, but basically they showed that the mean oxygen saturation did increase with delayed sequence intubation, almost to 100%. And more importantly, there was 0 complications in the procedure. The final intervention, and this has been a game changer for me, this study is not new, this was published in 2015, is this idea of back-up head-elevated intubation. So this was a study of 500 patients, and they got randomized to either back-up head-elevated to 30 degrees versus to the traditional supine intubation. And their primary outcome was intubation-related complications, which was one of 5 things. Greater than 10 minutes to intubate, more than 3 attempts to intubate, hypoxemia, which they defined as dropping your SATs to below 90%, esophageal intubation, or esophageal aspiration. I think those are all very good outcomes in terms of not being clinically important. And what they ended up finding is that the number of complications were significantly less in the patients that we started with the backup head elevated, as opposed to laying them down flat. So in all my patients now that I'm going to intubate, whether they're in shock or not, the head of the bed is 30 degrees until I'm ready to intubate. And then at that point, I lay them down flat. So with John, we did 15 liters per minute of nasal cannula. We started with a non-rebreather, but couldn't get his oxygen saturation greater than 92%. So we quickly moved to a bag valve mask with a PEEP valve. And that got his SATs up to 99%. And again, here's all the references with a QR code. Also, I put this in the OVA app. So pH kills. So this was the thing that sucked about John. Is it turns out John was a type 1 diabetic who wasn't taking his insulin, and his pH came back 6.8. So if he wasn't sick enough already, he was also acidotic. And I'm going to tell you the key message with acidosis is you want to treat the cause of the acidosis, There's no magic medicine that treats acidosis. Now, a lot of people will argue about bicarb, and there have been a lot of animal studies and a couple of human studies, and there's more human studies coming out now. But basically, when you give bicarb, all you're doing is you're making the labs look better because it makes you feel better as the provider. But actually what ends up happening is nothing good for the patient. And the reason for that is good old Henderson-Hasselbalch. You guys remember this from medical school? This equation sucks. But it's true. The more bicarb you give the patient, who's already breathing 40 times a minute to blow off all their CO2, is eventually going to get converted into more CO2. So you're eventually going to make your patient more acidotic. The more bicarb you give them, it makes labs look better, it makes providers feel better, but it does nothing for the patient, and you actually are making it harder for them in the long run. There have been 2 human studies that have looked at this, and they came up with basically similar conclusions. It makes labs look better, but it does not, in the long run, improve hemodynamics. So bicarbonate's not the answer. I did come across this interesting concept of Vapox that I want to talk about. This should not be something that anybody is doing until you have a protocol in place. It's called ventilator-associated pre-oxygenation. I'm not actually focusing on pre-oxygenation. What I'm focusing on is using the ventilator to help you ventilate the patient. So what do I mean by that? So the first thing you're going to do is you're going to put one of those non-invasive ventilation masks on your patient. You're going to connect them to a ventilator. Now, normally when we intubate patients and they're paralyzed and sedated, we put them on something called continuous mechanical ventilation or assist control. This basically means the machine is providing all the breaths for the patient. In this scenario, we've not pushed medications yet. So you want to use something called synchronized intermittent mechanical ventilation with pressure support. You're going to turn the respiratory rate to 0, and I know it sounds funny turning a ventilator down to 0 on the respiratory rate, but if you remember, John is breathing 40 times a minute. The next thing you're going to do is you're going to set your tidal volume. You're going to set it at 8 milliliters per kilo. I'm not stuttering, it's not a typo. 8 milliliters per kilo. This is higher than we traditionally do. We do 6 milliliters per kilo generally. And this isn't based on their actual weight. This is a common mistake that I see. This is based on their ideal body weight. Ideal body weight. You're going to set their FiO2 at 100%. Go ahead and set your pressure support at 5 to 10. The PEEP, you can dial up or down depending on what your patient requires. And then the last thing that's really important is this inspiratory flow rate. Typically on the ventilator, this is set at 60. But that's because we have an endotracheal tube down in the patient's airway. Right now, we have a non-invasive ventilation mask. If you run the flow at 60 liters per minute, you're going to start blowing up that stomach, and then they're going to throw up on you. So you actually want to cut it in half and turn it to 30. MD Calc is a free app that you can download. If you don't have this app, you should go ahead and download it. But this is a great app, and actually one of the calculators they have in there is you can put the patient's height, whether they're male or female, and it automatically calculates the tidal volume for you. So it does it based off ideal body weight, so you don't have to guess. This isn't guesswork. And then the last thing is you want to make sure you have end-tidal CO2 on your patient. This number, where the red arrow is really important, because as we go to push our medications, you want to make sure this number is not climbing. Because if this number is climbing, your patient's becoming more acidotic and likely going to code on you. You're going to push your RSI medications, and we decided we're going to do low-dose ketamine, high-dose rocuronium. You're going to provide a nice jaw thrust for your patient. You're going to set the respiratory rate to 12 as they become apneic. And now, whoever is the most skilled person in intubation is the person who needs to do this intubation. This is not a trainee's intubation, because you have one shot to get this intubation, first pass success. Because this patient is becoming acidotic because they're no longer breathing. We've taken that away from them. As soon as you get them intubated, you turn that respiratory rate up to 30 and your inspiratory flow rate up to 60, and you immediately check an ABG. That ABG will dictate how you need to adjust your ventilator. You're basically using the ventilator to keep blowing off all the CO2 that accumulated. This is part 3. So the one thing I always do a bad job about, we're almost done here guys, is I always forget to tell the audience how the patient did. And I'm gonna tell you that John was intubated successfully. We got him up to the ICU. He was on multiple pressors, he was on antibiotics, he was on fluids. Ultimately, John ended up dying within 48 hours from septic shock. But we were able to give him that fighting chance to maybe not die from septic shock by using all these different strategies. And we've all taken care of these patients. Don't forget about the physiologically difficult airway. Thank you so much for having me, and can't wait